acid-base balance. The pH of every physiological fluid is tightly maintained. For instance, pH of arterial blood is 7.4, venous blood is a little bit lower. By the way, why the pH of venous blood is a little lower than the pH of the arterial blood? Huh? Carbon dioxide, yeah, good. Intracellular fluid is about 7. That's ideal for all the enzymes and stuff. Okay. How tightly it's regulated? Anything above 7.45 is alkalosis. Below 7.35 is acidosis. It may not be pathological, it may be fairly benign, like a consequence of a diet, but still. So, what is the, let's define, talk about alkalosis and acidosis from sort of a clinical perspective. In the clinic, in the hospital, with the patients, what do you fear more, alkalosis or acidosis? Acidosis, all the time. You can get alkalosis, say, in people with anorexia that try to, they expel food all the time, they vomit often. That may lead to alkalosis, yes. But generally, it's really rare. Okay. So where does hydrogen come from? A breakdown of protein. Okay. Breakdown of lactic acid. Not breakdown, lactic acid itself. Fatty acids, not much. Ketone bodies. So we talked about ketones in the context of high-fat diet and diabetes. They both produce acidosis. The difference is diabetic acidosis is much more profound, much less controlled, much more unpredictable. Acidosis that occurs in case of high-fat diet is much more controlled. It's basically ketosis rather than acidosis. Now, this is another way to generate hydrogen. Remember that reaction, we talked about it a lot. Carbon dioxide plus water gives you carbonic acid, which then dissociates into the hydrogen and bicarbonate ion. And that is the basis for the buffer systems for bicarbonate buffer. Now, what regulates pH of the blood? The small changes in the blood pH will be controlled by the buffer systems and by respiratory centers. These adjustments are very fast. Does that make sense? In case of acidosis, your respiratory rate increases dramatically very quickly. However, the most potent control comes from the renal system. Although it's slow, but it has the largest influence on the pH of the blood. So what buffers do we have and where? Perhaps the most important buffer of the extracellular fluid, and often, referred to as most important buffer in the human body, is bicarbonate buffer. This part right here, that's the bicarbonate buffer. When there is excessive acid, it will bind to bicarbonate anion and produce carbonic acid. When there is not enough acid or excessive base will interact with the hydrogen, producing whatever. It buffers, so bicarbonate buffer can be found in both intracellular and extracellular fluid, but in terms of the importance in extracellular fluid, it's the most important. Okay? Good? Phosphate buffer. These two compounds. I promise you I will not ask the formulas of dihydrophosphate and hydrophosphate. This is dihydrophosphate, this is hydrophosphate. You don't have to know the formulas. What I want you to know about phosphate, though, phosphate buffer, is that it's the most important buffer of ICF, intracellular fluid, and it's also the main buffer of the urine. Good? And the third buffer system is the protein. Protein buffer system, you can imagine that there's a lot of protein in the intracellular fluid and in the plasma. That's where it works. So in the plasma, protein buffer is perhaps as important as bicarbonate. Okay? So if pH goes up, carboxyl group will release hydrogen. So pH goes down. If pH goes down, amino group will bind hydrogen. So far, does that make sense? So, the most important buffer of extracellular fluid in general: bicarbonate, intracellular fluid, phosphate. Urine, phosphate. Plasma, thank you. Plasma, bicarbonate, and protein. Protein is important too. Good? So, since we are concerned with the hydrogen, let's focus on the release of hydrogen in the kidneys. Okay? Let me ask you this. Which ion, which is somewhere there in the picture, which ion do you need to compensate for elevated levels of H+, the acid in your blood? Not CO2. Which ion, complex ion, will bind to H+ in the blood? Bicarbonate. So if you have acidosis, you somehow have to reabsorb bicarbonate. We good? Here's the problem. Bicarbonate cannot be directly reabsorbed from the urine. So you see this bicarbonate here on the left? See that? It's not reabsorbed directly. It can't just do this. Cannot go back in the blood. So there's quite a convoluted way to deliver bicarbonate in the blood and get rid of hydrogen. Look at this. In your tubular epithelium, right here, carbon dioxide combines with water, producing what? Carbonic acid. Carbonic acid diffuses into what? Hydrogen and bicarbonate. Make sense? Bicarbonate can be transported from the epithelium into the blood. So there you go. You get back your bicarbonate. Does that make sense? And hydrogen leaves epithelium and goes into the filtrate. Now, in the filtrate, it will combine with that bicarbonate anion, forming carbonic acid, and carbonic acid will dissociate into the water and CO2. CO2 will get into the cell to start the whole cycle again. So if you think about it, look at this. Let me erase all of it. It's kind of hard because everything is written, but the idea is to take this bicarbonate ion and take it all the way to the blood. You with me? Can it happen? No. What we do instead, we take this bicarbonate ion, get it in the blood, and then this hydrogen basically cancels this out. Does that make sense? So it's sort of an indirect reabsorption of bicarbonate from the filtrate. And remember, you can't reabsorb it in the true sense of that word. You see what I'm saying? So you get rid of hydrogen and bring bicarbonate back. Does that make sense? That's the main way to regulate, to get rid of acid and bring back bicarbonate. Oh, speaking of which, if you, for some interesting reason, I don't know, you drank a pint of baking soda solution, if you develop alkalosis, what would change in that picture? What would flip? These two will change places. Does that make sense? Bicarbonate will be excreted into the urine, and hydrogen will be absorbed back in the blood. Does that make sense? So, now we're going to bring together the renal regulation of the acids and bases and the respiratory regulation of acids and bases. Now, these few statements are really simple, really powerful, and in my opinion, really belong to what I call a duh statement. When your respiratory system fails, it produces respiratory acidosis or respiratory alkalosis. Let's take a look at it from clinical perspective. How can you produce respiratory first alkalosis? How can you increase your blood pH using your respiratory system? No. Alkalosis. How you increase? Huh? Hypervent. Can you imagine a patient that hyperventilates 24/7? I can't. Like 24/7 for like a week. I can't possibly imagine that. That's not a kind of reliable thing. Does that make sense? You cannot do that. You can have a patient like this, like temporary. How can you induce respiratory acidosis? Not stop breathing, but decrease deficiency, decrease pulmonary ventilation. Does that make sense? Can you imagine a patient with a low pulmonary ventilation? COPD. Chronic obstructive pulmonary disease will lead to decreased pulmonary ventilation and will lead to respiratory acidosis. Does that make sense? Now, what about metabolic acidosis, metabolic alkalosis? Well, first of all, we have to presume, and it's true, that if we talk about normal kidney function, then metabolic acidosis or alkalosis, they arise from some other reasons, not from the kidney dysfunction. We start with a presumption that kidneys are fine. Does that make sense? So what can produce, as we discussed, what can produce metabolic acidosis? Metabolic acidosis, not respiratory, something else. Huh? Say again? Yeah. Diabetes, uncontrolled diabetes. Anorexia will produce okay, so diabetes. Why? Too many ketones. Why too many ketones? I'm going to torture you now. Why too many? Not you personally, all of you. Why too many ketones? What happens in type 1 diabetes? What's not produced? Insulin. If insulin is not produced, what happens to glucose? It goes up, meaning it stays in the blood and not being reuptaken, not being taken into the cells. So cells don't have glucose, correct? If cells don't have glucose, they still have to carry out respiration. They don't have glucose, what they're going to use as the fuel source for respiration? Huh? Lipids first. They're going to use lipids. And as the result of the lipid metabolism and inability to run the Krebs cycle, they're going to start producing ketones. Ketones, such as acetoacetic acid and acetone, will make your blood acidic. Does that make sense? It's a long, convoluted story, but that's type 1 diabetes. Okay? Alcohol. The main reason for it, when you drink a lot, I mean, if you don't die, which is possible, but if you just drink a lot, alcohol will be metabolized into acetaldehyde. And part of the acetaldehyde will be metabolized into the acetic acid. There you go. That make sense? That's another example of metabolic acidosis. You can have diet induced. Hard, like really hard, to get it to the point when you're being sick. Okay, but high fat, high protein, low carb, or extremely low carb diet will get you there. Diarrhea will bring you in the metabolic acidosis story. Does that make sense? Now, alkalosis, as we discussed, vomiting, excessive vomiting, so anorexia, and taking antacids. So if you overuse your Prilosec or whatever, Tums, I don't know, that's not going to help. Okay? Does that make sense? The sources. So realistically speaking, acidosis is most common. Second, really important, the message. If the failure is respiratory system cannot compensate. If failure is metabolic, kidneys cannot compensate. Does that make sense? I call it a duh statement. If something is broken, it doesn't work. That's basically what it means. Which means that if somebody has respiratory acidosis, which system will try to compensate? Kidneys. And if there is metabolic acidosis, the compensation will be coming from respiratory system. We're good? Let's take a look. Now, this table at the bottom is not perfect, so I will guide you through this. And we're going to talk about acidosis first. And we're going to start with the respiratory. So we have a patient with severely diminished pulmonary ventilation function. Patient with a severe COPD. So what's going to happen in this patient? How will it affect CO2 pressure in the blood? No breathing, huh? It's going to go up. There you go. A lot of CO2 in the blood, right? CO2 accumulates in the blood. Okay? That make sense? So meaning that you have a lot of hydrogen ions. Correct? Now, how can you get rid of hydrogen ions? Remember, it's a respiratory acidosis. Which system will start to take care of it? Huh? Renal, kidneys. What they can do with hydrogen ions? excrete them, pee them out. So when you excrete hydrogen ions, let me write that equation down. When you get rid of this, what's going to accumulate? Upper right corner. Bicarb, right? Bicarb will start to rise. So what you're going to see in a patient with the respiratory acidosis, when the renal system kicks in, is quite paradoxical. You're going to see elevated blood CO2 and elevated blood bicarbonate. Does it make sense? Elevated CO2 from the poor respiratory function, elevated blood bicarbonate from the proper kidney response. We clear? Now, in alkalosis, the response is going to be absolutely opposite. So you're going to see initially declined CO2 and eventually declined bicarbonate. Does that make sense? It's kind of easy to remember. If you're not sure how to get there, it's kind of easy to remember. Although I don't encourage remembering it, I encourage working your way to it. But you know, both CO2 and bicarbonate are elevated in respiratory acidosis. Metabolic. What do we start with? Low bicarbonate, low blood pH. Which system is going to compensate for your metabolic acidosis? Respiratory system. How? Don't look there. If your blood pH goes down, if you're acidotic, what you going to do? Breathing wise. Not just breathe. How are you going to breathe? Fast and deep, right? So, rate and depth of breathing increase. How increased rate and increased depth of breathing affects CO2 concentrations in the blood? Decrease. So, in metabolic acidosis, you're going to see lower bicarbonate and lower CO2. Does that make sense? Do I understand what's going on? So, to kind of recap it again. In respiratory acidosis, your respiratory system, your ventilation is insufficient, so your blood accumulates CO2. In response to this, your kidneys start to excrete hydrogen ions, leaving bicarbonate in the blood. So what you see in the result is elevated blood CO2 and, as the response, elevated bicarbonate. In the metabolic acidosis, something happens and your blood pH goes down and the concentration of bicarbonate goes down because buffer systems work. In order to get rid of extra acid, your respiratory system now will start to excrete CO2. So what you're going to see in the end is low bicarbonate due to the original cause of acidosis and low blood CO2 because of the response. Alkalosis, flip it up. So, okay, respiratory alkalosis. CO2 concentration in respiratory alkalosis is what? Low. pH of the blood, obviously, high. How can you decrease pH? You retain hydrogen. How will it affect bicarbonate? It will decrease it. Does that make sense? So in respiratory alkalosis, you're going to start with low CO2 and it will progress to low CO2 and low bicarb. In the metabolic alkalosis, pH of the blood is high, meaning that bicarbonate is high. In this case, when you have metabolic alkalosis, how will it affect your breathing? It will slow down. since it slows down, CO2 in the blood will start to accumulate. So what you're going to see, the original change is very high bicarb, and the response, elevated CO2. Does that make sense? So be able to deduce, like, what happens, there will be a question. What happens in metabolic acidosis? What happens, I'm going to be focusing on CO2 and bicarb. Okay, these two parameters. Good? Easy part. Draining the urine. Ureters. Here. That's the cross section of the ureter. From kidneys all the way to bladder. Bladder pressure goes up, and these ends of the ureters close. Why it's important? So urine doesn't go back into the kidneys. Why we don't want urine to go back to the kidneys? It's sterile or not. Pressure increases, yeah, so it can increase intracapsular pressure. Another reason, if there's something nasty, growing in your urinary bladder, you don't want it to be spread to the kidneys. If you have cystitis, you don't want glomerulonephritis. Cystitis is enough. Does that make sense? Layers. Mucosa. Mucosal layer, the epithelium is transitional. Know that. Muscularis. When muscularis layer contracts, urine is expelled. Adventitia, just a connective tissue. On the right top, this one, it's a ureter. It's a cross section. Urinary bladder, that area here, called trigone, it's the most frequently infected area in the urinary bladder. Urinary bladder at the bottom, which sex does it belong to? It's kind of says here, but female. How'd you know? Urethra is pretty short. Females have shorter urethras. We get to this, okay? So the trigone gets infected. We call this infection cystitis. Women are at the highest risk for urinary tract infection due to, kind of feel, not my words, the words of actual professor of microbiology from Medical University of South Carolina. Intrinsic anatomical problems with plumbing. Okay? The urethral orifice and anal orifice are in the close proximity, and the carryover of microorganisms from the gut to the urethra is pretty common. And they can migrate upwards. Does that make sense? Muscularis is actually epithelium, again transitional. Muscularis is 3 layers. It's called detrusor muscle, so that's detrusor muscle, to squeeze the urine. And adventitia, you see no submucosa in ureters or in the urinary bladder. Now, 500 mils normally, okay, can stretch to about 1 liter. That's a lot. Can burst. Was the basis of the capital punishment in ancient Rome during the times of Tiberius. Ever heard? No? They basically put a clip on the penis of the slaves and gave them wine. Forcefully, they, how to say, not fed, but they were forced to drink wine, and the urinary bladder burst. That was pretty painful and slow death. Okay. Now, aside from that fascinating historical fact, urinary bladder has a really interesting capacity. Imagine you have a balloon, okay, and you inflate it. As you inflate it, the tension of the balloon material increases. Does that make sense? So the pressure that balloon exerts on its content increases too. Do you understand what I'm trying to say? Like you pumping something in a tire in a balloon, the material of a tire or balloon puts some pressure on the content. Urinary bladder has what we call a stress relaxation response. Meaning that when you drink water and your urinary bladder starts to stretch, as it stretches, it relaxes. You see what I'm trying to say? It stretches more, it relaxes more. So, although it stretches, you don't feel that pressure that would stimulate urination. This is why you can store quite a lot of urine, you know, in the urinary bladder. Does that make sense? Now that's male urethra. That's a female. That's female. I'm sorry. That's female. My bad. That's male. So female urethra is pretty short. Male urethra is longer, and it has 3 parts. This part is the prostate urethra because it goes to the prostate gland. This one is the membranous urethra because it goes through the pelvic floor. And this part is a spongy urethra because it goes through the spongy body. Okay? Corpus spongiosum. That makes sense. You see, male urethra is much longer. This is why males have lower risk for urinary tract infections. And in terms of the epithelium, almost entire urethra is transitional, and next to the external urethral orifice, it changes to stratified squamous. Do I need to explain you why it's stratified squamous? Near the orifice, there's a chance for some rubbing abrasion, so it makes sense. Both in males and females. Does that make sense? Protective response.
So this bottom blue box is for both male and female?
Yeah. The one that I'm erasing over now, this box, yeah, that's for males and females. Now, the efflux of the urine from the urinary bladder is controlled by sphincters, and that's going to sound super familiar. So you see the sphincters, the internal and the external. Let me see if I can find them here. Here you can only see, we're gonna get a bigger picture. No, we're not gonna get a bigger picture. So internal is here, external is here. Internal is controlled by parasympathetic system and is involuntary. External is controlled by somatic system and voluntary. Does that make sense? What does it remind you about? Digest. Yeah, same way defecation is controlled. And it turns out that urination is very similar. The reflex is similar to defecation reflex. So when you have a full urinary bladder, it sends the signals from the stretch receptors to the brain and to the spinal cord. So spinal cord is responsible for involuntary control, right? Parasympathetic activity goes up, sympathetic activity goes down, somatic activity goes down. Internal sphincter opens, external opens, you pee. Does that make sense? You understand? Now imagine that you don't want to pee. I mean, you want, but it's not appropriate. Like you are in the classroom. Okay? It's not appropriate right now. So what you do, you know that your bladder is stretched. You know that you want to pee. When your bladder is stretched, what's going to happen to your internal urinary sphincter? No, it's going to open. Bladder is filled, internal sphincter will open. You have no control about it. It's going to open. It's going to relax. But you have second system, right? You have external urinary sphincter. So your brain sends the signal to spinal cord and basically reverses this whole activity. So your external urinary sphincter doesn't open, and you hold your pee. And then, I'm kind of talking about the things that we do every day, you know. And then you go to the restroom, and your brain sends the signal, relax, you pee. That makes sense? So external is voluntary, internal is involuntary. There was a very interesting experiment once. I like those inhumane experiments where people suffer just for the pure curiosity. Curiosity was, how strong is the social prohibition of peeing your pants? I mean, we don't pee our pants as adults, right? Well, normally, if we're conscious, not drunk, okay, like, we don't do it. The experiment was that a group of students of some college were put in a room, okay, and they were explicitly banned from relieving themselves, except for, they were told no restrooms, they didn't have access to the restrooms, and they were not allowed to pee in a corner. So the only way they could do it is to pee pants. And they were given fluids. Probably they were paid for it too. They were given fluids. So few students passed out before they peed their pants. The prohibition, that social, mental prohibition, is so strong they just couldn't force themselves. Now, little children don't have that problem, first of all, because they don't have social prohibition, and second, they don't have the storage controls. The reason why a child doesn't hold the urine, doesn't develop that activity yet until about 2 or 3 years of age. So if you try to potty train 6-month-old, all you're going to do is to create a sustained psychological trauma on the poor child. I mean, they're just going to pee. Okay. Now, why? So a few things about micturition and retention of urine and the inability to retain the urine. Why urine is hard to retain in pregnant women? Yeah, uterus with a fetus presses on the urinary bladder. Why sometimes that inability to retain the urine lasts after the delivery? It's kind of a hard question. Part of the control over the external urinary sphincter are the muscles of the pelvic floor. During pregnancy, due to the stretch, these muscles can sometimes get weak. It takes time for them to get back to normal. Does that make sense? in elderly, sometimes muscles get weak and they have problems, retaining urine. Now, sometimes patients who come out of the general anesthesia have to have a catheter installed to drain the urine. You're familiar with that, right? The reason is anesthesia can mess up the signaling, the nervous signaling to this urinary sphincter, and they may be unable to open the sphincter. Does that make sense? So it has to be mechanically drained until all the effects of anesthesia go away. Does that make sense? Questions? Let's talk a little bit about an anatomy of the male reproductive system. As far as I remember, the anatomy portion of that exam is 35 or 40 questions. There are a lot of repetitions, so I'm going to be asking about the same structure in different views, lateral, frontal, blah, blah, blah. There's not much. So, first of all, we've got several parts. So, from the outside, what you see penis and you see scrotum. Okay? What's in the scrotum? The most important part of that is encased. Testes. Okay? So testes are encased into a layer of connective tissue that contains so-called dartus muscle and then so-called cremaster muscle. So the function of dartus and cremaster muscle to elevate and descend testes, elevate them into the pelvic cavity and descend them from. That make sense? Why it's so important? Testes require, sperm cells require a very specific temperature to properly mature. 2 degrees Celsius lower than the body temperature. So, when it's cold outside, dartus muscle and cremaster muscle will contract, pulling testes in. Makes sense, right? Into the warmth. When it's hot, testes will descend. Are we clear? There is sometimes a congenital abnormality called cryptorchidism. Crypt means secret. Orchidism, orcho, refers to testes in general. So, kind of concealed testes. In this condition, testes do not descend during childhood. They remain inside of the pelvic cavity. And that really messes up the maturation of the sperm. And if it's not corrected timely, leads to infertility. Does that make sense? Now, this is the lateral view of the human reproductive system. Now, I want to point your attention at some plumbing here. So this is testis, and this part is epididymis. In fact, epididymis consists of several meters of very fine tubules, where sperm is stored and it matures there. From epididymis, sperm enters vas deferens, or ductus deferens, passes all the way to the ejaculatory duct, through the prostate urethra, into the spongy urethra. Does that make sense? So you can see that male reproductive plumbing and urinary plumbing at some point merge. That make sense? On the way, there are 3 key glands which secretions are necessary to generate the functional semen. It's a seminal gland or seminal vesicle. It's a prostate gland and bulbourethral gland. So semen is the ultimate product of testes that produce sperm cells and these three glands that produce various types of secretions. So far, we're clear. Now, perineum is the space bound by the pubic symphysis, coccyx, and distal tuberosities, this triangle. Penis, organ of copulation, okay? That's a shaft of the penis. That's the root of the penis. At the very end, at the distal end, this area is called a glans penis, which is covered by prepuce or foreskin. The surgical removal of foreskin, as you know, is called circumcision. It's pretty common in the United States, which was unusual for me, really, because back in Russia, it's not commonly done to newborns, unless parents want, but usually parents don't really care. Okay? Now, are there any benefits to circumcision? You ask, I don't know, depends on who you ask. So it is shown, it's not necessary medically. If penis is kept in proper, there's proper hygiene, personal hygiene, then it's absolutely not necessary. There is a reduction in the risk of HIV transmission in circumcised people, but to be honest, the best way to protect yourself from HIV is to just wear a condom. Okay, so that's kind of not really warranted. It is a traumatic surgery, and as with any surgery, there can be complications, although they are extremely rare. It is true that circumcised penis requires kind of less care in terms of the hygiene, okay? Why those nationalities or ethnicities, like Jewish folks and the Muslim folks, why do they circumcise? Well, now it's a tradition, right? Was there any reason for this tradition to rise? Historians, medical historians, think that the reason was the climate of Israel, Palestine, and Arabic Peninsula. It's hot there. And the infections, especially infections of the, maintenance of hygiene maintenance and, infections of the reproductive system and, penile mucosa were pretty common. And they just figured out if we will get rid of the prepuce, it's easier to clean, and kids run much less risk of infection. So it's mostly, it probably stems from the hygiene requirements in that particular climate. Does that make sense? There is no such tradition in, say, northern countries. Okay? By the way, do you know where the foreskin goes? The one that is removed during the circumcision. It doesn't go to trash. I hope not. I really hope not. I really hope it doesn't go into cosmetics. No, it is used for research purposes. So skin is the invaluable source of fibroblasts, the cells of the connective tissue. It's one of the most commonly used cell for research. And getting samples of human tissue in any other way is hard. Just hard. So foreskin is abundant and cheap. and you can get a lot of fibroblasts from there. So basically, it is used by ATCC, organization, non-government, non-profit organization, to produce cells that you can buy human foreskin fibroblasts for research purposes. Okay, I really hope.
So they use it for just research purposes?
Yeah, they just extract the cells from it. Yeah, just, not throwing them away. Now, a little bit more about the tubing. So look at we're kind of getting deep into, that's the last thing we're going to talk about. So look at this. What, do they use it? Holy crap. Okay. I'm not saying you're crazy. I just think it's an insane idea. So that's the testis. If you would look inside, you will see a lot of tubing. So this tubing right here is called Seminiferous Tubules. This is where the sperm is produced. From the seminiferous tubules, sperm cells go through the straight tubules into the rete testes. You see that network that I just circled? The rete testes. And from rete testes, it enters into the epididymis, which is about 6 meters in length, very tightly packaged. When we were doing mouse surgery, part of the surgery was to take the testes out because we needed a cremaster muscle. God forbid you to damage epididymis, because then all this tubing falls out, and it's like spaghetti all over the muscle, all over the mouse. Getting rid of it is like it obscures everything from microscopy. You cannot normally do it. Okay, it's really, really long, really, really thin. So sperm matures in the epididymis and eventually enters the ductus or vas deferens. Okay? Does that make sense? Vas deferens is pretty long too. 1.5 foot. It goes all the way through the pelvic cavity towards the ejaculatory duct, and basically sperm travels in this exact order. Generated in seminiferous tubules, through the straight tubules and rete testis, gets to the epididymis where it stays for a while, and then moves towards ductus deferens, from which it is ejaculated through the ejaculatory duct, through the urethra outside. That makes sense? If you tie the ductus deferens, it's called ligation. Super effective form of a birth control. The original way of a birth control was to cut it. Now there's an approach to ligate it, so basically tie it down, okay, which makes it reversible, technically. It can be damaged. I mean, it's not 100% guaranteed, but, and on top of that, if it's tied down and one sperm cell will actually make it, it's going to be a champion. Right? Okay, so we're going to wrap it up, and